First and foremost, we'll talk a little bit about OCT versus visual fields and the relative capture of new glaucoma patients and how you can use both of those together to maximize your skill set. Corneal Hysteresis in glaucoma suspects, a really new paper by Felipe Medeiros. SLT is primary therapy. The LIGHT study, I think, has brought to the forefront probably the most important disruptive change in initial therapy we've had in a long time. And then the repeat SLT and then OCTA and glaucoma, which I think is an interesting subject, but not particularly relevant to us today, but maybe into the future. This is a piece of work by Don Hood. I'm going to preface all of this discussion about ganglion cell with this. Don Hood is the brightest mind I know in anatomy visual fields in the United States. He has basically built the nomograms for most of the systems and the algorithms for analysis. This is his work on ganglion cell anatomy. He was the first to really derive this. As you can see, there's this really notable difference in sensitivity of ganglion cells to glaucoma damage. The inferior arcuate bundle with that very clear step is much more vulnerable inside the macula than the superior bundle. So what we see is a really fascinating change in the GCC readout. This is what's called a wiper defect. As you can see, it has that beautiful inferotemporal sensitivity cut that Hood originally diagnosed, just sort of derived and was given to us. The reason this is important is in his original work back in 07 with Razo or 2011 with Raza, and then prior to that, 27 with Razo, what they noted was that you'll see ganglion cell loss before you see RNFL loss in about 25% of the patients. And so when I see a patient with a ganglion cell loss that's not reflected in the RNFL as a clear indicator of disease, or if the visual field's normal on a 24-2, I will then go back and I'll look at the GCC and say that's an abnormal GCC with a clear wedge. This patient has glaucoma. Let's go a little further. I'll do the next level of investigation involves switching from a 24 to a 10-2. About a fourth of the patients, approximately, will end up having a near fixation loss that you didn't see on 24-2 because the separation of the 6 degrees of the target elements is too large for you to physically find that defect. You need a more dense analysis, which is the 10-2. So this patient looks like they have a pretty normal OCT. The problem is that the OCT has a fundamental flaw, and that is that it is a extra large nerve. So it's a supersized nerve or megapapilla. Megapapillas were not included in the original algorithm analysis for the disease, for the glaucoma package on any of the devices. They use normal sized nerve between about 1.8 and 2.2 on average. So this nerve's a megapapilla. And what happens is, if you can imagine, this is your nerve size for normal. Your T-snit circles that nerve size, as you can see right there. And in a normal nerve, the T-snit is displaced 1.71 millimeters from the center of the optic nerve, which is based on the edge of the Bruch's membrane opening, which defines the nerve size for all OCTs. So that BMO becomes the centerpiece for the analysis. That 1.71 is standard in the industry. All of the data points and the analysis points are set to that. So as a result, when the nerve is extra large, instead of having the T-snit be this far from the nerve, now it's this far. And that distance decreases the relative analysis sensitivity. And what occurs is when you get closer to the edge of the nerve, we all know the fibers heap up as they elevate and then enter into the nerve. And as a result of that, you get this very unique misstatement of the nerve status. This could well be a glaucomatous nerve. What's reading is that because the nerve's so large, you're getting green disease. And the way to differentiate that is do a GCC. In this case, the GCC clearly shows damage, whereas the RNFL was normal. I see this. I'm doing a 10-2. You might even find this on a 24-2, but you might be confounded by the fact that the two are appositional. You have a loss, but the retinal nerve fiber is saying it's normal. Do the GCC. Conversely, in a patient with red disease, just the opposite. You have this unique situation where the nerve is too small. Now, this is a normal nerve, and now you have a nerve this big. So the T-snit is displaced far into the retina, where the nerve fiber layers are naturally lower in volume. And as a result of that, you end up in a situation where you'll see an eye that's flagged red and looks very glaucomatous, but in fact may be completely normal. If you run the GCC in those patients, typically it's going to be a normal GCC and a visual field, which also should be normal, which should tell you that this patient has red disease. You still may be suspicious, you should be if there's other indicators, but this is a patient where you do serial OCT over time to look for change on the GPA or the glaucoma progression analysis, as opposed to waiting or trying to make a decision on an initial eye. I mean, I've seen patients with completely normal eyes that have nerve fiber layers of 63. Why? Because they have a 1.2 optic nerve, and you're reading so far out into the retina that you have a existent thinner level of fibers at that point. So relatively speaking, GCC and the RNFL are partners in life, and they should be used constantly together. Another reason the GCC is critical, colleagues, is the GCC leaves the eye and enters the cerebral cortex. The analogy I would give you is if you're doing electrophysiology, the ERG is based in the retina. The VEP is based in the brain. Same thing with GCC versus RNFL. RNFL is a retina-based analysis. The GCC is a cortically based analysis. This is the Melbourne Rapid Field. It's a tablet, flexibly. I used it throughout COVID. I did over 300 visual fields during COVID. Conversely, there's a link that you can send to patients, and I was doing that during COVID, where I would send it to their computer. They would do the visual field at home based on the program, and then subsequently send the field back to me, and I would analyze it without them having to come in. I believe that visual fields are becoming unbundled as regards standard large bulb perimetry, and we're starting to see a massive shift into. And this was driven in large part by telemedicine, but it's also driven by convenience to the patient. All Eyes is a remote virtual reality system, which is beautifully done. Let me show you. So over on the right, this is the standard system that was done on the original studies. I love this device, and I love it because patients love it. Put them in a room. The beauty of this, you put this on. Now, if I turn my head left, the device is still straight in front of me. The visual field is straight in front of me. If I turn my head right, if I go up, if I go down, if I lay on my back, if I look at the ceiling, the device and the field are always straight ahead. In the bowl, you only had one straight ahead. Any deviation from that caused considerable variation in outcome. Corneal hysteresis has been around for a while. This is, without a doubt, the best tool we've ever derived to know who within the glaucomatous population is going to demonstrate progression. So this is your rapid progressor identifier, I guess would be the best way to phrase it. So this is the Falk multi-function device. This device basically replaces your gold mount tonometer. The activating system to the left, the little keypad, dictates which test you're going to run. You have three test options. You can do intraocular pressure, which is an intraocular pressure, but it's also a serial tonometer. So this takes, in this case, it took 70 and 64 readings in 10 seconds, measuring over 3 cardiac cycles. That multiple serial IOP measurement, the end value is an average of the outcomes, right? Systolic and diastolic IOP are measured. The average IOP is displayed. The IOP variation in the cardiac cycle, or the OPA, is measured. Second, ophthalmodynamometry. I used to do this regularly at the VA when I ran the VA eye service in Ohio after I finished my residency, because that's all we had. And we did it for the same reason we do it today. Patients with amaurosis fugax, patients with normal tension disease, patients with retinal vascular disease that's asymmetric, all have the potential to be identified as significant underlying systemic vascular disease patients by simply measuring the information that you can get from the mean central arterial pressure, right? Or the MCRAP. So the data captured during this is during 3 cardiac cycles, just as the T serial is. And the true ocular perfusion pressure, which is the OPP, is derived. So the MCRAP, which is really the central retinal artery pressure, is an indirect analog or a derivative representative of the carotid, cardiac and carotid pressure on each side. And then the final one is tomography. It's digital. It's phenomenal. I use this on every patient who I suspicion has glaucoma. You can just go to them online, the Falk Medical Multi-System. This is a tool that helps you create incredibly important information about you. So this is the Equinox, and this is one of the fascinating new devices. It's the first ever non-medical, non-surgical IOP control system. It uses a reverse vacuum goggle system that lowers pressure at night. The patient sleeps through the night with the goggles on, and the pressure is lowered as a result of that process. This device is called the CAT. So with a GAT, the measurement error from true intracameral pressure, or a pneumotonometer, is about 5. With his device, it's about 2.5. So what I would tell you to take from this is there are no devices that measure in this fashion that are absolutes. But if you want a device that makes you a much better clinician and narrows down your error range from this to this, so you have less error on every visit, which eventually evolves into a much more accurate assessment of the patient, this is the way to go, colleagues. This is an amazing tool. So this is Matti Therapeutics, a device that uses a punctal insert, much like a punctal plug, except in this case, punctal insert is devised in the following fashion. You have a drug core, which is then covered with a polymer sleeve and then subsequently shielded with the cyanoacrylate film. It's placed into the punctal system. It's a dead-end system. It's a one-way system, so there's no backflow. And the lysozymes from your tears cause you to have the drug slowly dissolve and elute into the tear film over a 3-month period. Ocular Therapeutics. So this is an extremely low-dose dexamethasone impregnated collagen plug. There's a little bit of cross-linking that takes place to give it the structure. They contend, and I think it's quite accurate, that they can put almost any drug they want into this eventually. I have yet to use this because up until now, it could only be used at the time of cataract surgery for reimbursement. Now that it's been approved for seasonal allergy, the use of these non-steroid drop systems, and there's several of them out there, is going to revolutionize how we do business in the glaucoma world. Durysta is the first approved intraocular injectable IOP controlling drug. This is a AbbVie, Allergan/AbbVie product based out in California. And it involves the placement of this pellet into the anterior segment. This is really exciting, colleagues, to have a drug that works this well, and it does work very well. We've used this countless times already to control IOP with almost no anterior segment awareness. The eyes are white, they're quiet, the corneas are clearer, the ocular surface is better. The IOP is better. IOP here is similar to what we get with Rocklatan and Vyzulta. It's close to 9 millimeters of mercury, it's about 8.5. If you have that same drug on the outside, you're getting about 7.4, maybe 7.5 max. So as a drug, it works exceptionally well. This is a Hydrus by Avantis. It's a Horizon trial. It was a study that was done. That's what they look like. So they occupy 1/4 of the anterior chamber. So you take a pizza and cut it in 4 parts. This is one of the pieces of the pie. It's a really useful tool because for most of us, I don't think we really understood up until recently that the Schlemm's canal is not an open tube for the patient's whole life. It scars frequently, and you have these adhesions or synechia within the canal. And one of the best ways to increase flow is to break those synechia and give yourself a full 360 exit. This is the Zen. And it's a gelatin material. And what happens is it's a tube procedure. So it's much like an Ahmed valve, as you can see on the left, except there's far, far less invasion to the corneal tissue. And subsequently, as a result, the ability to control hypotony is one of its greatest features. I find this to be a terrific device when you need 2 or maybe 3 drug reduction control.